speaker series. Today, we're joined by colleagues across the country who are going to help us kind of share their experiences along with some of our local experts. I'm going to introduce each person when I ask them to share a little bit. And then we're going to open it up for questions around 4:30. So there'll be plenty of time to have kind of an exchange at a bigger level for everyone who's involved. I know this is a problem that's been a big challenge, but I think we're approaching some solutions and hopefully able to learn a lot from all of our colleagues assembled today. So thanks everyone for joining, and thanks of course to our panelists. So I'm going to start by introducing Dr. Jeff Jager. Jeff is a primary care doctor, recently became an addiction medicine expert, and is going to share a case. But also, Jeff, give us like that one-liner about why you chose to go from primary care to addiction medicine. So I'd love to hear that.
Thanks, Jean Marie. As Jean Marie said, I'm a primary care general internist. I've been at Penn since 1997 and wound my way through a bunch of various interests while I was here at Penn. Started getting involved in addiction medicine in about 2018 when it became clear that not everyone was stepping up to care for patients suffering from this epidemic. And having trained during the HIV epidemic and seen how people started to make the choice to either be an HIV doctor or not be an HIV doctor, I felt like I couldn't watch another epidemic happen without getting engaged. And as most of you on the call know, that step turns out to be a very important step in your professional development because it's been a wonderful journey joining those who care for people suffering with addiction. So very proud to be Addiction Medicine Board certified now and one of the inaugural team on our addiction consult service. So with that little background, I'm going to tell you about a case that I was working with one of our fellows, and we were the addiction consult team for this young lady. So the patient that we're going to use as our example is a 34-year-old woman with a history of OUD, IV drug use, and chronic leg wounds thought to be related to xylazine, who was brought to the emergency department by family with concerns for worsening of her leg wounds. She was treated in the emergency room and eventually admitted to the hospital for treatment of her wounds, benzodiazepine withdrawal, and opioid withdrawal. Treatment was initiated with MOUD and phenobarbital as per our existing protocols, as well as short-acting opioids for pain. On hospital day 2, the patient was found with her head hanging down in her food. She was hard to arouse, but arousable. There was concern for in-hospital use. The medical team was notified and security was called to the patient room. So I'll stop there, and Jean Marie, you can take over from there.
Great. Thanks, Jeff. And I'm always inspired by your story. So we're from the same era, and, I think we all just love the work we do now. So it's great to see more colleagues joining the club. So we're joined by Dr. Ellen Eaton today, who it's just been lovely to meet. One of the fun things about these things is that, you could sit next to somebody at an addiction medicine meeting or just join new colleagues and join in our passion for this work. So it's been a pleasure. Dr. Eaton has come to us from the University of Alabama, and she's addiction medicine and infectious disease trained and works on sort of the ID service there. But it's just a question for you, Ellen. We know from our experiences here in your research, do you have strategies to approach concerns about substance use in the hospital prior to a security search?
Yeah, we are not perfect here. I'm glad y'all are asking this question. I think that we play a vital role by addressing these things proactively, as you alluded to in your question, before there is a crisis or a security event. I think this is, and from our prior conversation, this is a great place for the peer, a peer recovery coach, a peer support person. And you could envision this being part of their intake checklist to counsel the patient what to expect in the hospital, to, as I mentioned on a prior discussion, offer to take the patient's baggage to their family, to their boyfriend, out in the car, counsel them, we're going to be treating your withdrawal, your pain, we're going to be treating your chronic substance use disorders. Is there anything in your bag that I can go ahead and take out that you won't need here? So being proactive about getting anything that they may have cravings for, or be inclined to use during this day. And then I think even using them in place of security, in place of that officer who may, per protocol, come around and go through bags and go through bathrooms. Could we think about bringing a peer into that role to make it more patient-centered, less stigmatizing, and more of just like a well check-in. Let's let's do a well check-in. Let's make this part of our protocol. Again, we're not perfect here. We're not doing that here. We're incorporating peers into more of our work, but I just think there are so many roles that we have medicalized or criminalized that really a peer could do in a way that is much more palatable to the patient and their families.
Thanks, Ellen. Got like a landline ringing here, not sure. I want to introduce Rachel McFadden, who is our opioid stewardship nurse and has just been an amazing partner in working to destigmatize care from the emergency department. Also works at Prevention Point, which is our syringe exchange and wound care program. So it just brings a lot of expertise and is just a lovely friend and colleague. So could you just share some of your perspectives about what you hear from patients about the concern of going to the hospital, how they may prepare for the hospital, and kind of other thoughts on how to address this?
Yeah, thanks, Jean Marie. So I work at a wound care clinic at Prevention Point Philadelphia, which is a harm reduction organization in Philadelphia. And we see a lot of people who need hospital care but don't go to hospitals because of the anticipated stigma and lack of pain and withdrawal management. So we do, but people do need to go to the hospital sometimes. And we've been able to help facilitate kind of warm handoffs into hospital care and do kind of in-reach to help advocate for people. But we get to have some pretty frank conversations with people that are harder to do in a hospital setting about, when do you use in the hospital? Why do you use in the hospital? And I think, it happens for the reasons we all know and that are published in the literature that Ellen and others have found, which is that pain and withdrawal are not managed. But we're, I think in places like Penn, where we are doing a lot to proactively treat people's withdrawal, or trying to do a lot more, I should say, treat people's withdrawal. Sometimes people still use. And I think, one kind of perspective I've heard from folks, and that makes sense, is, just as we have kind of practiced a very certain way, or we have given care a very certain way to people who inject drugs or who have substance use disorder for a long time, those people have gotten care in hospitals for a very long time in a certain way. And that means getting well right before you go in and bringing enough drugs with you to be able to stay well, to get your medical care, because you anticipate that your pain and withdrawal will not be managed. And that, I think, has been going on for a very long time. So, kind of on a larger scale, it will take time for us to really change our practice and our culture around caring for people with substance use disorder and anticipating their needs and meeting them in really person-centered ways. But it is also going to take, a culture shift in a community of people who uses drugs, to really trust us to do that and not bring their stuff with them, or be more able to give it up in a conversation like Ellen suggested, that feels really kind of comfortable, even if it's with a peer, or especially if it's with a peer. But that's just not the norm right now. You have to keep your stuff with you so that you can get medical care. So I think we have to allow time for that kind of culture shift to happen as well.
Thanks, Rachel. You always bring such great insight. Dr. Barnett, thank you for joining us. Dr. Barnett is an addiction psychiatrist from the Cleveland Clinic, and also the associate fellowship director there in the addiction psychiatry program. So, with the escalating experiences of our patients in the hospital, this probably happens more frequently to your addiction fellows, when they're on service. Do you have strategies to like teach them how to kind of manage or de-escalate these situations when, when they're, these become a likely encounter with a patient and with staff?
Yeah, so thinking back to my own fellowship, it seemed like I got called to these situations almost every day. I was at Brigham and Women's Hospital, and yeah, these issues came up a lot. And so what we tell our fellows is to, I guess it's good to mention the background first, and that's that in general, hospital staff, the fellows, there usually are not hospital policies in place to guide what they're supposed to do in these situations, and JCAHO does not have a policy around this issue either, and so it's just sort of this vortex that they have to navigate on their own, and these can be pretty intense interactions between teams and patients, and so we tell fellows when they go into these situations to really kind of focus on framing at the beginning with hospital staff. Provide some education about why the patient might be using, if they are, and this goes back to what Rachel said, things like withdrawal not being treated, pain not being retreated, and then also emphasizing what's at stake in this interaction. So these, if patients are using the hospital, they're more likely to leave early, more likely to actually die after they leave the hospital, and I think that helps put things in perspective. And then determine whether use is actually happening, because there are cases where it's suspected, but no evidence is really ever found to confirm that it's happening. And I think we'll touch on this later, but there are tools like the hospital misuse checklist that can be used to sort of gather evidence to determine whether this is actually happening, not to be used to find a reason to kick the patient out of the hospital or something like that, but to make sure that there's objective data to indicate what's actually going on. And then talk to the patient in a patient-centered manner. And I think in these situations, often there's a large group of team members present that can be very, very intimidating to the patient. So it's better to have those conversations one-on-one if possible, or with the fewest number of staff there. And when talking to the patients, kind of approach things openly, just checking in, how are things going in this hospitalization? What's going right? What's going wrong here? And then emphasize that our first priority is their safety. And use open questions when talking to the patients. Ask them, have they been using? If a search is something that's going to be done, ask them if that would be okay. We really want to involve the patient in these processes, and then of course with security, that's really that kind of the last thing that you would consider. That would only be if there's imminent harm that's likely to come to the patient or staff. And so we always try to do whatever we can to keep security out of the situation if that's possible.
It's a great summary of the status. And, as we tried to write our policies, we realized the same thing, which is there are some publications that help guide an approach, but there isn't anything hospital policy wise that helps guide us, other than a lot of policies about not being allowed to have substances, in a hospital. I'm just going to pivot for 1 second, just ask Jasper. Jasper is Jasper. Thanks for joining. Jasper is also a longtime friend and one of our HUP security, so one of our hospital security guards at the hospital that I work at, and has really worked hard to focus on this topic in a way that de-escalates. Jasper, do you just want to make a comment or two?
Yeah, hi everyone. Thank you for inviting me. I'm delighted to be here. This is to me, this is personal. I got 25 years sober, and I clean and sober, and I share that information with everyone that I work with, because it's a tool that is very useful. I can walk into a room even though I'm dressed like I'm about to invade Poland and introduce myself as a peer. That I get it. I've been there. I've done that. And drug addicts and alcoholics are more likely to speak to somebody who has a personal experience than anybody else. So, and I agree with everything that's been said. I always secure, if possible, the person's permission to go through stuff and emphasize that this is safety. So, I mean, this is not something that we can use for a security team who only have maybe 1 or 2 people who are sober. So, but it's something that I use frequently. I will say one thing: when you approach somebody who's using, always be 2. It is my experience from doing multiple 12-step calls. The nature of the disease when you're in the throes of it is that you will manipulate to try to get what you can out of desperation because you're in a position of being powerless. It's always good to have 2 people, because I remember myself, I could not help giving people the runaround to manipulate to get what I needed to get well. And so there's that. I hope that we can. Peer support is what are they called? The people that we have hired to be peer support who are also, but that is just the greatest decision I've seen since I've been at Hub, because you need people who can identify with you, or you're not going to get very far in most cases. So anyway, great. I'm so happy to be here, and I can't wait to see what we're going to do with this. And Rachel, thank you for correcting me. It's to be well, not to be. Rachel and I had a conversation about the language that we use here. So it's very important to me to be here. Thank you.
Thanks, Jesper. Always great to hear from you. So Ellen, back to you. I know in one of your studies, you found the association with illicit drug use in the hospital associated with early or patient-directed discharges. So we know that, and the number might be 30 or 40%, even maybe even higher. But for that 50 or 60%, the people who do stay and don't leave, what are the factors associated with retention in the hospital despite a search? Just so we can kind of target how to do this better.
Yeah, and we haven't specifically looked at factors associated with staying. I can tell you the group that leaves is the same group that uses in the hospital, and they have a whole host of surrogates for severe substance use disorder. So I pulled up our checklist to make sure I could remember all the variables. It includes things like cravings, an unstable home environment or being unhoused, dual psychiatric diagnoses, a history of overdose, history of multiple relapses. And I realized we put this together in 2016. I don't think we would use that term. We would say probably return to use, to be patient-centered and use person-first language. Polysubstance use, so using stimulants is very common here amongst opioid use disorder, but using more than one substance. A family history of substance use disorder, a history of trauma, and a limited what we put in our checklist as limited willingness to change. And I also don't know if that's the right term to say at this point, but this was put together by one of our addiction psychiatrists, and he just felt like there's a group who, when he's offering them treatment, when he's offering them pharmacotherapy, they're not ready. So that is the group. Those are the factors that are associated with leaving early, using in the hospital. They're also more likely to get an addiction medicine consult early. So I think, we've only done our studies looking at our health system retrospectively. It's not a clinical trial, so there's a lot of confounders. But I think what this tells you is this is the group that is sick. They're demanding care. They're probably paging their nurse a lot. They're asking for PRN medications. Maybe they're leaving the floor frequently, and the team does not know what to do and pages addiction medicine, exasperated. You've seen this play out on the floor, on the wards, right? We don't know what to do with this patient. Addiction team, is paged over and over until they hustle to the bedside and hopefully are able to provide a therapeutic alliance with the patient. So I think taking that other group, subpopulation, then Jean Marie would be the group who is not having cravings, does not have these factors. That is the group that is more likely to stay. And these are not, it's not rocket science, right? You probably could have independently come up with these variables, but I think in an ideal world, in a resource limited setting or a hospital with limited resources, if we have some sort of risk tool like this, and we can, Jesper, to your point, if we can identify this group and get them a peer, maybe they have an intensive peer intervention. It's starting in the ER. Nice to meet you. You're going to be staying with us for a few days. I'm going to be checking in with you. Here's my pager. If we could really wrap that group with a strong, supportive contact that is patient-centered, I think we could do a lot of good for this group.
Thanks, Ellen. That's really thoughtful. And, when we spoke earlier, you brought up this whole idea of peers and daily peer visits to keep people both engaged in care and to keep this prevention focus, which I think is really great point, and something that we really hadn't incorporated into our policy or our guideline yet. So I really like that idea. Rachel, I think just to kind of ask you, when you're, the nurse at the bedside, which you frequently are, I know you've been involved in times when this has gone well, when the patient feels like they were supported. And, a lot of us understand that this is the disease and that we kind of have to help people help themselves to prevent this, because, like you said, they're coming prepared, and yet they might also think that this is going to be the hospitalization that leads to, a longer period of recovery. But it's that but I need a backup plan. So tell me how you I've seen you spend a lot of time with your patients. Rachel's hard to find because she's always at someone's bedside. But tell me how you do it.
Well, I think prevention, coming from a prevention standpoint, and it's prevention, but it's also just like Ellen just said, kind of building an alliance with the patient as soon as possible. And I don't know if, these conversations actually do prevent use in the hospital later on. I see people in the emergency department, not later on. And I think it's maybe a little hopeful to think that if I say the right words, then someone's cravings will go away. But I do like to tell people off the bat that, we care a lot about safety here, and we care a lot about you. And I want you to feel well enough to get the medical care that we know that you need. And we want to take care of that. We want to help you with that, just like we want to help you with your medical need, just like we, whatever you're presenting with, and just like we want to help everybody with what they're presenting with. So I really hope that you'll let us do that and communicate with us how you're feeling. And if you're feeling cravings, that's something we want to know, because we want to treat it. And I understand you've probably had experiences where you've had to use in the hospital in order to get through. I totally get that. But in the same way that we don't want, any patients to really be using their home meds, so that we kind of have a better idea about what's going on and what's in people's systems. We also would prefer that we treat you with our meds. But we really want to open dialogue. Got to just tell us how you're doing. And I think it serves a couple, it can be helpful in a couple ways, because it's, we're not hiding from the fact that we know people use in the hospital. I mean, I think some of the literature out there says like 30 to 40% of people report using in the hospital. I said to Jean Marie the other day, I think, from my conversations at Prevention Point, I think it's probably more like 100% of people. So acknowledging that in a warm way, like, I know you had to do this to get medical care, and I'm sorry about those, that's the case. We want to help you with this. I think that is one person-centered kind of way to go about it. And, I also think, what does person-centered mean? It means being responsive to the individual's kind of preferences and needs. And I guess going back to what I was saying before is like, this person may end up using and may end up leaving. That is, going to continue to happen. We're not going to fix that with the right conversation. So being, knowing that and being prepared with some harm reduction type responses if and when that comes up too. I guess having like a backup plan, and also being able to tell someone like, it's okay, I understand, please come back whenever you're ready, and meaning that. But I think, again, you can have a lovely conversation with someone and that doesn't fix their substance use disorder, but it can help build an alliance that, helps build trust and can help set them up for, hopefully coming back.
Thanks, Rachel. I see a hand up. We were just about to go to audience questions, so let's do it. And also the panel can feel free to answer these questions. So think about it, and I think I'm going to have to ask the panelists to at least unmute to respond. So James, please. And for the audience that's going to be asking questions, if you don't mind, if you could turn on your camera or at least tell us who you are. So go ahead, James. Thanks.
I'm James. I work at camp now. I used to be at Prevention Point with Rachel. Rachel is amazing. But yeah, I think to some degree it's magical thinking that peers are going to get these people through what they're going through when this is something that, like, I don't know, I find very daunting, is that the dose on the street is just so high. It's so high. And these people are so sick and their wounds are so intense. It's like, we recently had a patient that came in and stayed for 3 days in self-discharge and said it was the best that he had ever been treated in a hospital, which is wonderful. But there's going to be patients that I know him and I know that he's easy to deal with, but there's going to be patients that are going to come in and they're going to be tough, and like, are we going to be able to serve them in the same way?
Thanks, James. It's a challenge, and I don't disagree with your component, but I also think that's why we have every discipline on this call, or many disciplines on this call, because we know it's literally taking a village to address this, and we're working on building that village and expanding that village. So I appreciate everybody who's here. Sam Zweibel, nice to see you.
I'm Sam Zweibel. I'm over at HUP Maine, and a lot of people with opioid use disorder, consultation liaison psychiatrist. When we were doing the chart review for the patients with the xylazine positive and negative fentanyl positive urines, what I kept seeing over and over again was times where a patient had been found basically slumped over in the bathroom, or there was clear concern for use, and in the discussion with the patient about, hey, we'd like to search your stuff because it looks like you have used, and it's documented, so it's very poignant, where you can see the provider typing in their note, like, we tried so hard to be non-judgmental, and we worded it this way, and we said, I'm sorry that we weren't treating you well enough, and all of the things that we're talking about were done. But ultimately, the patient still ends up saying, all things considered, I'd rather leave right now. And I was wondering if we have advice for what to do beyond, how you word things, because it's so sad reading those charts where you can see the PAINS team saying, I did everything I could. It was so non-judgmental. It was a quiet, calm conversation. I used the right tone of voice. I used the right language. I told them it was my fault, and they left anyway. What can we do?
I think that's
Can
such a good point. Yeah. Ellen, and then Stacy and Judy. Yeah.
Yeah, thank you. Just one thing that I've been thinking about in conversations preparing for this is that even the notion of why and how long they stay in the hospital is often a very paternalistic decision. And I think a lot of us are having to reframe what we deem appropriate hospital care. At what point does a patient say, I'm ready to leave, I feel well enough to leave, and we need to rebuild our care models to do what we were going to do up on the medicine wards and do it at their house. I mean, I think we're to that point where we just have to acknowledge there's a not small percentage who's ready to go before we are comfortable leaving them. And, you know, this is probably a whole nother discussion, and you may not have wanted this to go in that direction, but I do think
Well,
there's
and I guess you said at their house. What house?
yeah.
Like what house?
And where could that be? And I know there are groups that are doing this. I know or like Honora Englander at OHSU, and I know Laura Fanucci at Kentucky are both doing studies where they're trying to look at these models. Is it some interim skilled facility? Is it a board and care type environment? You know, could the IV antibiotics, like how could that look? And I don't have a perfect solution, and it's certainly going to look different for different patients and different payer statuses and political climates. But I do think that we really need to ask ourselves, you know, why, when we say you have to stay, do you really have to stay? And if not, on a case by case basis, what could a therapeutic environment look like for this patient given their desires? You know, from what y'all are describing, you are doing a much better job than we are here. I think there's a lot more paternalistic care here, my way or the highway. And, you know, nobody report back to my boss about that. But culturally, we're just in a different place in Alabama. And I think that a lot of what we don't feel comfortable, cases that we don't feel, patients we don't feel comfortable discharging, could probably do just fine, especially now that we're getting a lot of oral antibiotics. You know, a lot of the things that we previously kept them in for, IV antibiotics, you know, being one of them, we now have some long-acting injectables, some oral options, you know, injectable, you know, pharmacotherapy for opioid use disorder. So I think that we really need to, I think the status quo isn't working. I think that's why we're here. And so thinking about totally disrupting the system and where is the best place and allowing patients to have more say in that. And I know it's going to be expensive and I'm in a Medicaid non-expansion state, but I do think that we need to start thinking about that.
I love that. Love it. Thank you. Stacy, you were next, then Judy, then Rachel.
Stacy, I think you're on mute.
Oh, I'm sorry. Hi, I'm Stacy. I'm a PA here on the hospital medicine team. I just had a question, and I'm sorry if this was discussed in previous panels, but have we kind of talked about maybe having like a safe injection site that's associated with the hospital? The reason I'm interested is I'm taking a class to try to see if I can do my MPH, and my project will be looking into something like this, and if we can do something associated with Penn Presby, because our addiction services team is amazing, and I think it's really cool, all the work that you guys are doing. And I think that there is something similar at one of the hospitals in Chicago. So I was going to look into that too and see if maybe if this is something that we are interested in, I could try to present my research to you and see if that's helpful in any way.
Thanks so much. We didn't plant her to tell us what a good job the consult service is doing, but we'll note that. Thank you. I see Peggy Compton on, or Rachel, if you just want to respond to the exploration of an overdose prevention site. I know we have had some conversations. I know there's a Peggy. I don't know if you can talk.
Yeah.
Yeah.
I can
Great.
talk, but I can't be on camera. Can you help
Okay.
me?
No problem. No problem.
Yeah, no, Rachel French did a very nice study interviewing key stakeholders at HUP about the possibility of it. The last draft I saw of the paper, and I should have looked at it before getting on this meeting, was that a lot of it came down to logistics. Where would it happen? How would we get them to the safe place? How many patients could we actually accommodate? So it seems there was a fair amount of really support for having a safe injection, site, or the opportunity for safe injection behavior within the hospital, but a lot of logistics around that. So I think that's kind of the bottom line. Rachel, was there anything else you pulled out of that analysis?
No, I agree. I think that's what we found talking to clinicians. I think the political climate around it is probably the greater challenge. I mean, we are work at one of the most well-resourced at Penn, health systems, and I think we can figure out the logistics, but I think the political climate around it makes it a little more tricky. And, and if that's how it is here in Philadelphia, I think it's probably like that in a lot of places.
Yeah, and if it's the political climate, that could be explaining why people are so concerned about logistics.
Great question, Stacy. And it's an obvious, like, we've sort of put it out of our mind because of the external challenges we've had in opening an overdose prevention site. But, kudos to the team that looked into this internally. And it's shocking when you read their report, there was not, absolute opposition, maybe because it was more in the abstract. But really interesting thoughts. And pursue your work, Stacy, because we'd love to hear more. If you just change the question slightly, you can explore it further. So great. Judy, I don't see if you're still hand up, wanted to make a comment.
Hey, it's Eva.
Okay.
I'm circling back to Sam's kind of original question around perfect documentation and doing all these things right, and then things still aren't working. I just want to bump M's message earlier in the chat that trying to approach this in just a physiological or medical way is we're missing why our patients are here in the first place, and that the underlying reasons that people are using drugs is because things are really, really hard socially, compounded by in the hospital, even with the addiction consult team, I can only be with patients for so long before I have to see other folks. People are alone in a room without fentanyl and without tranq and without stimulants, with nothing but their thoughts and trauma to kind of sit with. It's just really hard being here. And I think maybe that I wonder if that's harder for our physician friends on this call to hear, that it doesn't have to be that you've done something wrong or haven't added enough Dilaudid or Benzo or whatever it is. Being here is a huge deal. And I'm just gonna, for emphasis, it is so fucking hard to be here alone in a hospital room, even if all of your other needs are met, even if it's freezing outside, even if it's so hot outside. Sometimes being here is so miserable that it's better to leave. And we have to sit with that, just we haven't solved those problems. And that's okay. And it's also okay that patients need to leave sometimes. And it doesn't have to be about us in that moment or what we did or didn't do. It's just about the patient. And thanks for for bringing that up in the chat earlier.
Thank you. And I see, I'm just getting a look at the chat, which I didn't quite realize. I would have gotten massively distracted. So I'll catch up with that later. But there's a lot of great work happening in that exchange. So Eva is one of our social workers, or the social worker on our addiction medicine consult service at Presby. I just wanted to add that to your introduction. Thank you for your work, of course, and for that comment. Jasper, back to you.
Yeah, hi. So for the last 3 years, or since before the pandemic, I've been part of the anti-racism task force at HOP, and we have gotten into talking about trauma-informed care in detail, because we're dealing with trauma talking about trauma, this is just one of the traumas we're discussing here, and all the social stigmas and everything that's going on. And Dr. Sun and Dickinson has actually started taking this very serious and implementing education in trauma-informed care for the residents, and hopefully nursing is going to get more involved. It is important that people feel safe. If we had more support staff who could help making people feel safe by having these conversations regularly and supporting nurses and clinical staff. You guys have 4 or 5 patients, you can't be there all the time. So getting that education out there is of paramount importance, because if we had more support staff who could spend the time making people feel safe by listening to them, one of the most basic ingredients of trauma-informed care is to make sure that the person knows that they're being heard. Okay, you don't have to agree or disagree with a person. You just have to gain an understanding of where the person is at, and the empathy will come, and the patience will come by itself to any healthcare worker. Okay, so this is something that we can definitely do. I work for security. I know for a fact that we could train hospital security to be in trauma-informed care. We have CPI, but it's a very watered-down version of trauma-informed care. It's something that we can look into and maybe get in place within the next couple of years. And lastly, don't be discouraged. The percentage of people recovering from addiction is very, very small. We cannot let that get in our way. We just have to keep going. I had a conversation with a friend, and this is the third time I've seen him this month with a leg source from Tranq. And, you know, the nurse told me he was here. We had a conversation first thing this morning. I just keep plugging away with it. And as far as I know, he's still with us and he's going to get his antibiotics. I did crack a joke this morning. I says, you don't have to go anywhere. The dope we have here is better than anything you can buy. And he just cracked up. Yeah. So,
Thanks, Jesper. Fun fact, Jesper is a security guard, but he used to be our trauma chaplain. So, you know, it's rare that you find that fused specialty in a security guard, but he's really a wonderful asset. James.
Jasper, I was sort of waiting for you to say, like, yeah, we can bring security in because a trauma-informed or a trauma-invested environment requires everyone. And Ava, thinking back to sort of like what you were saying, like Gabor Mate, MD, says, like, the question is never the addiction. The question is always, why is the pain, right? I'm like paraphrasing here, but it's pretty close to that. And so it really does take a trauma-informed approach and a person-centered approach where you're genuine, where you show unconditional positive regard, and where you can, I mean, you know, show accurate empathy. You may not have stuck needles in your arms, most of you, but like, you know, you're still like somebody who can, it means a lot when people feel heard. It means a whole lot to be in those spaces and feel like someone is treating you with dignity, you know, because I've certainly been like, you know, I've been treated pretty badly at a few different places, and yeah, it makes you not want to go back for sure.
Yeah, it's a logical behavior stimulus response, right? Sarah, and then I want to also get to Danny from the health department had some questions. If you want to plan to unmute, we'll let Sarah go first. Otherwise, I'll read your questions. Go ahead, Sarah. Thanks.
Okay, great. So hi, everyone. I'm Sarah. I'm a med student, and I'm working on a project actually trying to better understand when patients undergo room searches while they're hospitalized. And one thing we're seeing is that patients are often searched multiple times when they're hospitalized, like within the same hospitalization, and then also if they come back. And maybe this is, I'm not sure who this would be directed to exactly, but I'm wondering if you guys have seen that, how you think it affects the doctor-patient relationship, and also Jesper, if you have any thoughts on your experiences searching patients multiple times. I think that would be helpful for me to understand.
Go to any length to get the person's agreement. Even if you have to take the time, sometimes it takes half an hour, and trauma-informed care, listening, making the person feel safe. Hospital security is about making people feel safe. Using force is a last resort. So, I mean, again, it's a matter of education and having these conversations. We're just getting started here, but I'm very hopeful.
Thanks, Jesper. Thanks, Sarah. Danny, can you unmute, or do you want me to just read your question? Oh, great.
Sure,
Thank you.
I can unmute. Yeah, I was just, I'm really curious if there's any protocols or best practices, when you recognize that some use is happening, to provide that person with naloxone, penile test strips. There's some EDs that provide sterile syringes, wound care kits, if they're going to be leaving early and have a wound. So the hospital is a place, like we mentioned, of riches. So, there's an opportunity to for the person to leave not empty-handed if we are recognizing that they are, actively using substances.
That's great. I see Judy tried to respond to your question in the chat. I don't know if you want to unmute Judy. It sounds like she had an experience where, yeah, go ahead.
We're not entirely sure if the patient used overnight, but the fact that she slept well means that maybe she did. But when she woke up, there was no like security involved or anything like that. But kind of when she woke up and felt ill, she asked immediately to leave, and the team called us right away, and we were able to talk with her and say, okay, like if this is your plan, what can we do? And so we had already come up with a plan for like how she could get wound care, transition to oral antibiotics. We provided her with wound care kits, lots of Narcan. We provided her with information for how she could access care in the future. And again, like she left maybe before the team was comfortable. But we also actually worked with the team to see this as the patient's choice and not have her leave as a patient-directed discharge, but as a shared decision-making, that her choice was to leave the hospital and to get the care she needed at home, which was actually totally medically appropriate, maybe not preferred, but a reasonable option for her. So we kind of changed the trope a little bit on what it looked like for her to leave. We've got like 3 extra hours. Eric bought her soda, actually got her mom linked to care, who was with her in the room, had some, I don't know, let Eric speak to his conversation, but like we had things happen, so she didn't leave abruptly, and we're able to get her what she needed. So I don't know if you have anything to add, Eric.
I know generally it was like one of those like moments like where if you look at it with the wrong like scope, like it felt like a failure, but it was honestly like the best outcome because we had an educated approach through like multiple facets of what education means, lived experience, doctors, social workers, all in that moment, like work together to figure out the best outcome for that moment. And she left relatively comfortable. She left with like, a new set of people that she trusted that she could come back to with information that like, not only she needed, but her mother needed. It was definitely like way better of an outcome than we could have imagined, even though it didn't go the way we wanted it to immediately.
I love that story, and I love to build on Ellen's sense that we are too paternalistic, and that's for sure true, and that's probably more of a physician problem because we think of our care settings and our dogma, and we're sometimes too rigid. And also, I think we think that patients can't get care anywhere else, as optimally, but of course they probably can. So yeah, thanks for that point of view. And thanks, Eric. Eric is one of our peers on the consult service, and wonderful to hear from you. Jeff, you had your hand up.
Yeah, so many thoughts since I started this conversation off now 40 plus minutes ago, and so many notes I've made. But one of the important
things, and now they just stopped it over at the university. So there's a couple other ones they go to and they utilize. Here's one of the docs I work with.
Judy, I think you guys are not on mute.
Nope.
That's not you. Oh, it's not you. Oh, sorry.
I
went
on Eva's excellent point, and I think James made the point as well about the physician as well as the nursing culture that it's ingrained in us to think of in-hospital use and patient-directed discharges as personal failures. I'm not sure where that came from. I know it's part of who I am as a physician, and it's been a major transition as I've become more experienced in addiction medicine to view events like in-hospital use, patient-directed discharge, even acting out at staff as part of the disease process and not a personal failing. And I do think that one of the important things we can do in addiction medicine as consultants is convey that culture to the medical teams, to the medical students, to the interns and residents, but also to the nurses. And one of the important things I've learned in talking to nurses about this is the extent to which nurses take ownership of their corner of the floor and the outcomes of these patients, and the extent to which a poor outcome reflects poorly on the nurse and his or her sense of personal self-worth and professional self-worth. And that shift, I think, is going to be a huge piece of this. And we can't assume it's there. It's one thing for us to walk in and say, okay, well, it's, like, this isn't the best place for you to get care, without acknowledging the trauma to the junior trainee and the new nurse and the physical therapist and everybody else who's viewing this as a personal failure. So I think we can go a long way towards improving the approach by including the whole team in our personal journey here. So I'll stop there.
Thanks, Jeff. I'm going to call on Rachel, and then I'm going to also just open it up to any of the nurses who haven't spoken up yet, because this has really been something that we all feel is a big patient safety issue, and we want to collaborate with floor nursing and everybody to make this safe. It's about safety and collaboration. So go ahead, Rachel.
Well, I don't know that I could say it better than what Jeffrey just said. That's exactly what I was going to put in a plug for, really involving nursing in these conversations, like literally the same conversation that you have with the patient about, we understand you might have cravings and we want to do our best to take the best care of you. And, let this be, like, have that conversation with nursing too, because I think sometimes nursing needs permission to be understanding of patients, and also modeling on different ways to talk about substance use disorder. And there's a lot of kind of interesting things about nursing culture that we could talk about. But one thing is our continuing education kind of infrastructure or practice is just very different from physicians. And if you got no training on substance use disorder in nursing school, which none of us did until maybe the last couple years, there's not a lot of support out there to get that education. And so you are kind of in the same headspace that you were 10 years ago, in just having absorbed, from the milieu that, like, this is how we do or don't take care of people with substance use disorder. And this is how we feel betrayed when people, leave the hospital. So I just, I think that there's so many opportunities to reach out to nursing, both to include them in, like, a care plan, a concrete care plan, and then allow them to vocalize, what are your safety concerns? And, the flip side of that is some nurses can use, and many people can use, safety as like a kind of veil over stigma. Their concerns are for safety, but is it also that they, just don't like working with people who have a history of drug use? So just kind of opening up conversations to allow some of that to air, and making sure that the person who's spending the most time at the bedside is, included in the plan. And I just wanted to also go back to, so Sam works with a lot of patients who are experiencing prolonged hospitalizations for, like, complex cardiovascular surgeries. And so, when somebody leaves that service, the stakes are much higher than, like, oh, you know what, we could actually just safely discharge this person with some antibiotics. And I think that's a different and very and much more challenging situation. I saw that Amanda Bocelli is here, is one of the social workers on the CT surgery service, who does amazing work building, lasting relationships with patients and their families who are on this service. And if we would love to call out Amanda, first of all, just to say that she does incredible work and maybe has some insight on how to navigate those trickier, higher stakes situations.
Oh, thanks, Rachel. Katie is on here as well. She's my counterpart, and I couldn't do it without her. I think the most important thing when working with patients who are quote unquote difficult, and Katie and I were talking about this yesterday, is just the fact that we just keep coming back. Like, when we first meet with them, they often, don't really want to talk. They're in withdrawal. They don't feel good, and they kind of are, rightfully so, just don't want to talk. But we keep going back and establishing that rapport and getting them to trust us. And I really do think it helps them to stay, to have a solid support and advocate throughout their stay.
Yeah, I think a lot of that brings up continuity, which we don't have in the ER, which we don't have on the hospitalist service, which we might, we do have on a consult service, but not, not on the weekends. And, so there are episodes of care that you're starting over again. That's probably why the searches happen more than once, because it's a new care environment or a new team or a transition. So it is a challenge. I wanted to hear from Stacy Thomas, just one more person, and then we'll wrap up.
Oh. Hi. Oops.
I don't know
Hi.
if
This
your
is
hand was up from before. I'm sorry.
No, this is actually Jillian Narrow. I'm one of the hospitalists. I'm with Stacy.
Oh, okay,
Hi.
that's fine.
I came from an institution. I came from Jefferson. We had a lot of OUD, and we had different practices there. And I just wanted to ask about ketamine and seeing if we commonly use ketamine drips, especially in hyperalgesia syndrome, and even with microdosing as a adjuvant to help with that bridge, especially in folks that had horrific skin and soft tissue injuries, things like that. It's such a great tool, and it's really underutilized at Penn. I was actually surprised coming to Penn about like the hesitancy with things like PCAs and ketamine. I also wanted to just say a quick note on the culture of discharges, because I've noticed that's pretty different here. I tried to run my teams at Jefferson to when we did have a discharge of someone who might have been earlier than what the medicine team wanted. Sometimes it was very dangerous to Rachel's point, with folks with serious cardiac complications of their OUD or strokes, that we were really worried that it would be very unsafe if they left. And sometimes it was something we can optimize. But I would always provide walk-in methadone clinics, wound care services, walk-in health center resources as a packet when they did choose to leave. And I have those all in dot phrases. I noticed a lot of the culture here, especially with residents, is that if they want to leave, do a self-directed discharge, that we don't do anything at all. We don't even help them into a wheelchair if necessary, which I was very surprised by in terms of a harm reduction model. I just wanted to bring that up in terms of a cultural shift. I try to address that as a teaching attending, but that's a little thing that we can talk about that could really make a big difference.
That's great. Thank you so much. So are you at HUP or Presby?
I'm at all of them and Cedar.
Okay. There is PO ketamine at HUP. We've been working to get it at Presby. They can use it, I'm sure, in the ICUs, but not on the floors where people need it. So, but those are great points, certainly about that abandonment when a patient says, I'm leaving, and we're like, okay, you're on your own. It's great to hear that in a city and a hospital just 2 miles away, there's a different approach. So we can't say things are different in Philly if we can copy that. There are some Jefferson people on this call, but I think just to wrap up, our goals of having this discussion, which I just really have incredible gratitude to everyone who participated and planned this with me. And thank you so much to our panelists. But everyone who came, has such a vested interest in improving care here. And I'm so appreciative of that. We are working to draft a more acceptable guidance around this issue. And I think we've gained a lot of insight on that. And we will share it with our panelists as we go, and hopefully everyone else. If anyone wants to join the working group on this, we swore we weren't going to make it like belabored for months and months, but we've met a couple of times. There's a couple new meetings. Feel free to email me on the camp website or email Natasha, who is on as well, Natasha Rohax, or anyone who who can get you to us. And we would love any more participation, because these have been a lot of great ideas. And this is a work in progress. It's a dynamic change. Our substance supply is crazy now, and we really need to work to mitigate all the different substances that our patients are exposed to. So I just want to respect the end of the hour. Thank everybody, and happy Thanksgiving. Be grateful. We are truly fortunate to have each other and to have all the things that we have. So thanks, everybody.
Thank you, everyone.